everyone, and welcome to the Self-Management of Chronic Musculoskeletal Disorders at Work webinar. We're glad you're here with us today. My name is Tanya Hyde, and I'll be moderating the webinar. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is part of our Return to Work, Stay at Work series. It's made possible through the support of the Community Gaming program through the BC government, as well as donations and memberships to ourselves, the CIRPD. As I mentioned, my name is Tanya, and I'll be moderating the webinar and handling the Q&A session today. And our speaker is Dr. Stephen Bevan. Dr. Bevan has conducted research on high-performance work practices, employee reward strategy, staff engagement and retention, and good work. He has a special interest in workforce health and well-being, a leading number of national and international projects focusing on workforce health and the impact of chronic illness on productivity and social inclusion. He is an advisor to a number of UK government departments and has advised employers and policymakers in Europe, Asia Pacific, Australasia, and North America. He is also chair of the UK Fit for Work Coalition and director of the Work Foundation's Health at Work Policy Unit. And I will hand it over to you now, Dr. Bevan.
Okay, thank you very much. It's great to be here, and it's great to be able to talk to you about this topic. I'm sitting currently in London, and what I want to talk to you today about is really some work that we've been doing looking at musculoskeletal disorders in the working age population. Some of the work that we've been doing is really trying to get under the skin of how you provide maximum support to people who have a musculoskeletal condition, who want to remain at work, or indeed return to work after a long period of being out of work or having long periods of sickness absence from work. What I'll do is just give a very quick background about what the Work Foundation is. We are a not-for-profit organisation that's been in existence since 1918, so almost 100 years. We started off as an organisation called the Boys Welfare Society. It was set up by a priest in East London who was concerned about factory conditions for young boys. It evolved into what you might call a social enterprise, and in the subsequent years it was focused on workforce well-being, and it became the Industrial Welfare Society. Then it became the Industrial Society, and the Work Foundation was its latest manifestation, and we launched that manifestation in 2002. In 2010 we were acquired by Lancaster University, which is one of the top 10 universities in the UK. The work that we do here in London is very much about bridging both academic and clinical research and policy and practice. So the work we do is applied research. It's not academic research or clinical research. The work we do is really trying to find solutions that is informed by the clinical and academic evidence base in this area. So our interest is to try and make sure that the work that is done by ourselves and others has practical implications and can inform policy. We do a lot of work around chronic ill health in the working age population. So in addition to the work you'll hear about in this webinar on musculoskeletal health, we do a lot of work on mental health, particularly on depression, anxiety, but most specifically on schizophrenia. We've published reports on the impact of inflammatory bowel disease, such as Crohn's disease, and employment recently. We're doing work on cancer survivorship and work. We're just starting a new European project on the impact of multiple sclerosis on employment. And we've also done systematic reviews for the UK HTA authority, which is called NICE, looking at the impact of workplace interventions on work outcomes for people of working age. And we just finished one looking at aging, health and work. Now, what I want, as I say, I want to focus on musculoskeletal disorders, and I'm going to use the shorthand MSK or MSD, just to shorten things. And I just want to set the scene really, so that everyone's got a clear view about why musculoskeletal disorders are so important in the working age population, both from a clinical and from an economic and social point of view. So there's a big economic story about MSK and lost productive capacity at work. One of the things that most developed economies are facing at the moment are big problems with labour productivity. There's obviously lots of talk about deficits and GDP growth and so on, but actually underlying it, most developed economies have got a problem with the productive capacity of their workforces, particularly if you have high levels of unemployment. But even in the UK, where unemployment is dropping, we still have historically low levels of labour productivity. And I think our argument is that we need to think very carefully about whether or not the health of the working age population, if we can improve it, could add to the firepower of our labour market. We also know that musculoskeletal conditions contribute to a very significant burden of disease problem, and I want to talk a little bit about that. We strongly believe from our work, not just in the UK but globally, that musculoskeletal conditions need to be raised up the policy priority list, particularly as workforces across the developed world age. We believe strongly from our work that work needs to be embedded as a clinical outcome and a treatment goal in the way that physicians talk about musculoskeletal health. Quite often they don't think about work as a potential aspiration or need for patients who have chronic musculoskeletal conditions. Our work focuses on several outcomes, so not just people staying in work, but their ability to return to work. And we're very interested in what type of work people are doing. So it's not just, our view is that we shouldn't just be focusing on any job, that good jobs have strong therapeutic benefits, and that we need to be thinking about the quality of the jobs that we're giving people, and that's a challenge for employers particularly. We believe in taking a biopsychosocial approach, which is essentially looking not just at the physical symptoms or the people's psychological well-being, but the social support they have around them. So taking a whole person perspective on this, just getting people's symptoms stabilised physically is not enough if return to work is an outcome we want. And we're also interested in providing support and incentives to employers to invest in prevention and early intervention, as well as rehabilitation, to help people they currently employ live fulfilling working lives. And then the final point, which is really the link into the rest of this webinar, is about empowering people. Too often the healthcare system or social insurance or health insurance or social welfare systems tend to do things to people who are suffering from chronic musculoskeletal pain. And really what this is about is thinking about how we can provide an environment where people living with MSKs feel confident to disclose, and also that they develop the skills to self-manage their condition, not just in clinical settings, so not just about managing their pain, which of course is important, but how they manage it in workplace settings, so we can maximise the sustainability and the quality of the work that people do. And that's a really important challenge, and that's where I'm going to really focus my attention. Now, one of the challenges we have in the UK, and I suspect in other countries too, is trying to get policymakers, practitioners, clinicians to think about the size of the problem. So this is one of the ways we've been doing this in the UK, just to illustrate how we're trying to set this in context. In 1978-79, it was the year with the largest number of working days lost to industrial action. And it's something that is still remembered in the UK. At the time, all the newspapers said that 29 million working days was an intolerable drain on the economic resources of the country. Every single newspaper was saying we must do something about it. It's a scandal. Now, in 2013, compared with that 29 million, we lost 31 million working days to musculoskeletal conditions, and no one took any notice. It's very interesting that when you compare the drain on productivity and also the human costs of musculoskeletal conditions, they're very significant. They remain, along with depression and anxiety, the biggest cause of sickness absence from work in most developed economies, and that's certainly true in the UK. And that is going to get worse as the workforce ages, as I'll demonstrate. Musculoskeletal conditions, if you look at the global burden of disease data, are the second cause of disability worldwide in terms of disability-adjusted life years lost. And almost over 21% of disabilities worldwide are attributable to musculoskeletal conditions, and the biggest single cause of disability is back pain. In terms of the working age population, just along the bottom of this slide, some data from the European Union, so 28 member states. Over 44 million workers have a musculoskeletal conditions that they attribute to their work. It costs about 2% of GDP across the whole of the European Union. They account for half of all absences from work and about 60% of permanent working capacity. So that's people leaving the labour market permanently. So this is a big issue, and it has big economic and social consequences. One of the problems is that musculoskeletal conditions are not considered to be a priority non-communicable disease. And that's partly, I suspect, because they have relatively low mortality. There are some musculoskeletal conditions like rheumatoid arthritis where there's an elevated risk of cardiovascular disease. But in general, because they're higher morbidity, so the disease burden is high, but not many people die of them, one of the problems is that they have relatively low priority in terms of health priorities, health spending, and also prevention. And I think because it's affecting so many people at work, that's something we need to change quite dramatically. Just finally, in terms of the context, here's some data, again just from the UK, but I suspect the pattern will be similar in other countries as well. Looking forward at the number of people with long-term conditions in the working age population by 2030, you can see that musculoskeletal and mental health conditions are dominant in this sort of pie chart. The key thing, of course, is recognizing comorbidity, so the proportion of people who have multiple conditions at the same time. So at any one time, between 25 and 30% of people with a musculoskeletal condition also have comorbid depression or anxiety. Now that affects not just the ease with which they can be treated and the ease with which they can manage their symptoms, but it also has an effect on the ease with which they can stay in work or return to work or cope at work. And one of the problems, I think, with some musculoskeletal conditions, particularly those that involve chronic pain or fatigue, is that there can be a tendency to catastrophize, which can can elevate people's anxiety about the condition, which means, for example, they might not use a limb or their back or their shoulders and so on for fear of doing more damage, which can lead them into a downward spiral. So keeping moving, keeping active and so on, for many musculoskeletal conditions can be the best way of doing things, and it can elevate your mood. So we need to have a clear understanding of how musculoskeletal and mental health conditions interact with each other. Now, as part of our global project on musculoskeletal conditions, it's called Fit for Work, we've written reports about over 35 countries around the world. It started off in the UK in 2007, but in 2009, for example, as you can see here, we wrote a report about the Canadian labour market. We've also looked at Russia, Japan, Korea, Australia, New Zealand, all EU member states, Turkey, and last month we published a new report looking at Brazil. So it's truly a global project. And essentially in these reports we're saying this is what the burden of musculoskeletal disorders are in the labour market, and these are the interventions that seem to make most difference. And one of the key things is what role that individuals who are living with these conditions can play to more actively manage their condition at work. So why we want to focus on self-management? I think one of the things that we've seen in terms of clinical settings is a stronger emphasis that if patients become more knowledgeable about their condition, they're in the best position quite often to understand, for example, if they're getting an inflammatory flare from an inflammatory condition, or in what circumstances their musculoskeletal condition gets worse or better. It's really important that we empower people to play a much more active part. And obviously in many settings, it's true that people tend to believe or obey what their physician says that they should do. And of course, up to a point that's true, but they need to be more active participants in that process. And shared decision making, for example, needs to be a part of how that's done. And I think there are some parts of the population who feel more actively able to do that, but there are others who find that much more difficult, particularly if they feel cowed by the authority of the physician and don't feel able to question what he or she is offering them. So self-management is one of those things in clinical settings that's becoming more prevalent, and I think it's pretty clear in many studies that people benefit from that both psychologically and in terms of their ability to recover and feel in control of their condition. And we did a previous study in Europe where we did some survey work amongst people living with chronic musculoskeletal conditions, and we found that those who reported that they were playing an active role in self-managing their condition appeared less anxious about retaining their job. And we were interested in getting a bit more information about why that might be. And what we found was that there's less emphasis on self-management in workplace settings or in vocational rehabilitation. And yet, the requirement on many employers in most developed economies to make reasonable adjustments to people's workplaces in order to help them rehabilitate to work is already there. It's enshrined in law. It's part of the legal duty of care that most employers in most countries have. But the tendency is for those, particularly for some conditions, to be done to people rather than with individuals being the active participants. So the concept of self-management in workplace settings is a relatively new one, and one which we felt merited further investigation. So in September last year, we published a report which is based on some qualitative research. So it's really based on literature reviews and then interviews with experts and then participation from a number of people living with chronic musculoskeletal conditions who are kind enough to be interviewed at some length by our research team. And so some of what I have to say in a second will be based on that study. Perhaps it's worth starting off with a definition. This is just one. There are many of them, but this is the one that we used within our study. It comes from Barlow. Self-management refers to the individual's ability to manage the symptoms, treatment, physical and psychological consequences, and lifestyle changes inherent in living with a chronic condition. Efficacious self-management encompasses the ability to monitor one's condition and to effect the cognitive, behavioural and emotional responses necessary to maintain a satisfactory quality of life. Thus, a dynamic and continuous process of self-regulation is established. Now that's quite important, that last part for us, because it is the dynamic nature of self-management, the fact that it's a sort of constant adjustment process and that people go through various stages of self-management, I think struck home to us as being true from the previous work that we've been doing with patients, patients who are workers living with musculoskeletal conditions, and that was certainly borne out through the qualitative research that we did with the participants in this particular study. And of course there are a number of benefits, both clinical and workplace benefits, to encouraging and supporting people to develop more self-management skills. For example, these are just some that are taken from some of the literature. People by and large are more able to take appropriate exercise and diet. They're more motivated to do it, and they know what the benefits are as part of the self-management process. They're better able to develop mental strategies to cope with chronic pain and fatigue. Their knowledge about their condition and therefore their ability to advocate for changes in medication is also important. I've been part of a global project looking at people's awareness of their own rheumatoid arthritis, for example. One of the things we found in a survey that we've done amongst them across the world is that there's a quite high disconnect between pain and disease activity in people's perceptions. So if someone has severe rheumatoid arthritis in their hands, many people still believe that if they're not feeling pain, then their joints are no longer being damaged by the disease, and that's not true. And so getting people to think that, to recognize that a lack of pain, possibly as a result of medication, doesn't necessarily mean that their joint damage is stopped, is really important, because if people are not in pain, they sometimes stop taking their medication. And so self-management helps people understand that they have a part to play, and they need to recognize how physical and psychological symptoms need to trigger a particular response or a strategy or a conversation with their physician. Strategies to cope with fatigue are really important. Fatigue is one of those things that a lot of people, particularly with inflammatory conditions, talk about, and they emphasize, as they did in this study, that fatigue is not just about feeling tired. It's something much more fundamental and draining than that. The ability to set goals, set and achieve goals. So self-management can provide people the ability to be very much more solution-oriented, and there are studies that show that people who have an internal locus of control, i.e. they're the sort of people who say, if something is not going right in my life, I'm going to choose to do something about it rather than just sitting back and letting things happen, also have better outcomes. The Chang reference there is reference to a study that shows a strong relationship between internal locus of control and self-management amongst people with chronic obstructive pulmonary disorder, but there are many other studies that reinforce that view that taking control of things can deliver better health outcomes. Maintaining a positive outlook is a really important part of this. People's mindset is very important here, and also cultivating discipline and motivation in the way you manage your condition. You can see, if you think about how all these attributes and benefits of self-management are transferred to a workplace setting, where you're wanting to make sure that the nature of your work, the demands of your job, and your ability to cope with that in a way that enables you to continue to be productive and contributing at work is a really important part of this process. One of the things we found when we conducted our research amongst people who, to talk to them about self-management, was that most participants had quite a high level of familiarity with the concept in its most basic terms of self-management. They understood it to mean having control over your condition and not being overwhelmed by it. And self-management was also constructed by many people as a gradual process where competence to self-management, to self-manage your condition developed over time, but I guess could also fluctuate, and that's something that is not necessarily a linear process. We found that the nature of the individual and the nature of the condition that people had also had a bearing on self-management. Some individuals talked about the management of their condition as a fight or a battle. Others spoke about approaching the condition with a positive attitude or just getting on with it despite the condition. So the sort of psychological mindset that people had really did make a difference to their ability to manage their condition at work. Specific aspects of the condition, including the way that the disease course is unique to each individual, particularly for some conditions such as rheumatoid, but osteoarthritis and others. And that the first onset of symptoms are often very hard to control before appropriate medication is being received. So what we found was that the information that people got at the point of diagnosis or how they felt before they were diagnosed can often bleed into the way they perceive the condition and their ability to cope with it even after they're better informed about it. And so that's there's a case there for early diagnosis and having early conversations with physicians about how the condition may affect people's ability to work. And we found, certainly in other studies, that having a good, positive, constructive conversation, a realistic conversation about workability, particularly for people who worry that leaving work might have severe financial consequences, is quite an important part of this. We also found from our interviews with people that symptoms of pain and fatigue were often cited as being really key for people to keep under control, partly because when they're talking to about their condition to co-workers, fatigue and pain are invisible, and sometimes they felt that people didn't really believe that they were suffering as much as they were saying, or that they might not believe it, and so there's a lot of sensitivity about the so-called invisible symptoms of some of these conditions. Participants in the study also talked about the ways they gathered information to assist them in managing their conditions. So, of course, physicians, patient organisations, the internet were key sources of information. They also talked about sort of general self-management techniques that included things like, understanding what your limits are, pacing yourself, building in rest, having appropriate exercise, and also making psychological adjustments to the process of living with a chronic condition. And obviously those are often underpinned by the need to make sure you've got a good medication regime underpinning it all. We found that participants in larger organisations and in public sector organisations had much better support in place. Obviously, if you have access to occupational health and other professional support, then it can make that a lot easier. We found that people who worked in much smaller organisations found that a lot more difficult. And we also found, as you'll see in a second, that a significant proportion of people felt that becoming self-employed was probably the best option for them, in the sense that that's the ultimate environment within which self-management can work. Now, there are obviously different views about that. One of the things we found in the UK, for example, is in the last 5 years, 40% of the new jobs that have been created in the UK have been self-employed people, and yet we still have 90,000 people a year moving from self-employment onto disability benefits. So the notion that a growth in self-employment is all about re-sparking of entrepreneurial spirit perhaps needs to be regarded with some cynicism. It may be that for people with chronic conditions, particularly towards the end of their careers, are moving to self-employment because they can't get real jobs and it's almost like a waiting room to early retirement. So that's something we need to be very careful about. We also found that line management was a really important part of this. Individuals reported varying degrees of awareness amongst line managers, and the relationship between the line manager and the individual was really key. A good, strong, understanding, empathetic relationship that developed over time often meant the line manager had a greater degree of understanding, and also that the individual felt trusted and more able to ask for and help design workplace adjustments. And many of our participants felt reluctant to ask for help for their line manager or disclose even that they had a diagnosis, and they were obviously fearful of getting negative judgment or feared job loss or that their careers would be over. We also found in general that our participants felt that their colleagues often lacked awareness about musculoskeletal conditions, and for some people that led to a fear of disclosing to colleagues, and they didn't want to be singled out, for example. Now there is literature about the sort of stages of self-management, and this is just one example from Audiluf. I've underlined the fourth stage. So the first stage is seeking effective strategies. Second is thinking about the costs and benefits, and that's not just financial. Third is creating routines and plans of action to help you adapt. The fourth one I think is particularly relevant in the workplace setting because it does involve some negotiation. And that, I think, has been the big emphasis in the work that we've been doing to understand a little bit more about how people in organisations go about the process of negotiating within their organisation as part of that self-management process. Now, we think that self-advocacy is a really important part of this. Being able to say confidently, without exaggeration, without catastrophising, how your health condition affects your ability to do your job, how it marries up to the demands of your job, and whether or not, either on a temporary or a permanent basis, some sort of negotiation about adjustments might need to be put in place. Now, as I mentioned, a lot of people are fearful about the consequences of disclosure. So, to your boss, to your co-workers, there's worry about whether or not your pay will be affected, or whether your careers or career progression will be affected, or whether or not you'll get different tasks allocated to you as a result of perhaps a misunderstanding about the type of work you're able to do. I was speaking only a few weeks ago to someone who had a diagnosis of multiple sclerosis, and their employer thought that all they needed to do, please don't ask me why, was to give them a desk near a window. And as far as they were concerned, they made all the appropriate adjustments they needed to do. The individual had not been consulted at all, unsurprisingly, and the employer was convinced that they'd done all they needed to do to make that person's work easier. So you still get some slightly wacky attitudes out there that we need to challenge. And the person to challenge them is the person living with the condition, but they need to feel supported and confident in doing so. People are also worried that they won't get access to training opportunities, or they may be first in line if the organisation needs to make redundancies or cuts. And certainly in the UK, we still have situations where organisations who are making redundancies look at the sickness absence record of people in some circumstances in order to choose who should go. So of course, if you've got a chronic condition and you've had a lot of sickness absence from work, or you have to attend medical appointments, that can be quite a scary prospect. The other thing that I think is important from this is we need to think about whether or not people should feel satisfied with any job, particularly if you're in a country with high levels of unemployment or particular sectors aren't doing so well. If you're in a job where actually your skills aren't being used, or you're subjected to anxiety perhaps because of increased job insecurity, quite often the rhetoric is, well, you should be happy with that. One of the things I want to address just at the close of my presentation is the issue around job quality. It's all very well saying we want to support people to self-manage themselves at work and to play an active part of work and to stay in work or return to work. What type of work are we talking about here? Self-confidence and self-efficacy is really important. Self-efficacy is the belief that you can do something if you try, and it's linked to self-confidence. But it has strong behavioural consequences. If people have high levels of self-efficacy, that is confidence that if they put their mind to it, they can do something. That is a big issue and a big bonus for people with chronic conditions who are seeking to self-manage their condition at work. But of course people are fearful that they'll get judged as having special treatment. For example, if they can work flexibly or work at home, that their co-workers may not be understanding about that. Being a burden to the team, and that's particularly the case if you've got teams of people who are working towards financial bonuses as part of their performance management regime. What you don't want to feel is that you're a passenger in a team, and that causes a lot of anxiety. Indeed, some of the people we interviewed, we felt that they had been putting so much into their work in order not to be a burden that they were completely wiped out when they got home in the evening, and they spent whole weekends just lying in bed recovering from work because they were so anxious not to feel a burden or to stand out or to be judged harshly by their colleagues, and that's clearly not a sustainable position. The key thing here is about using workplace adjustments to co-produce mutually advantageous solutions. In most cases, in our experience, if you're living with a chronic condition, and you can avoid just thinking about what I want, if you think about what will help your boss to make those changes, think about how your boss wants to make sure that productivity is maintained or customer service is maintained. If you think laterally about how an adjustment could be mutually beneficial both to the organisation and to you, then you've got the ideal solution. Often people don't feel empowered to do that. But I have never met a line manager who doesn't appreciate one of their staff coming along to them with a solution rather than a problem. And I think that's something that we learn a lot from those people who felt that they've managed their condition at work most effectively. So worker-led but supported adjustments are certainly best in this environment. And of course, if you are living with a chronic condition or a fluctuating condition such as a musculoskeletal condition, the best person to know what can be done to support your work is that individual. So it shouldn't just be a council of line managers, occupational physicians, occupational therapists and so on deciding on behalf of the worker. The worker needs to be in the lead in this process. And where that happens, our belief is that the outcomes are better. And someone in our study said the best adjustment you can get at work is to have a great line manager, which at one level sounds trite, but it really is part of the whole pathway to improving work outcomes for people. There are various models for interventions that help people to develop those sort of self-management skills. Here's one, which is probably the best known one, which is Kate Lorrick's Stanford model, initially developed for people with arthritis, but there's now a more up-to-date version that focuses on a range of chronic conditions. And I've given you the link there to some of these programs, and there's a link at the end of the presentation to some publications, so the ORI reference is to that as well. So that will be available when the webinar is posted online. But these are the sorts of things that the self-management programs try and deal with. Now, what I want to do just towards the end now is to just give you a few examples from our participants of the real things that they said about the context within which they're trying to self-manage their condition. Because I can bleat on for a long time telling you, but the voice of the person with the lived experience, I think, is always brings these things alive much more. So I just picked a number of themes and some quotations just to give you a sense of what we found in our study. So this one's about adjusting the rhythm of work, and actually this is a really important aspect of the way things are done. I think this quote is quite helpful. So as far as helping me, perhaps being a bit more lenient with my hours, that would have really helped, because I kept killing myself to get up early, so I could be in work for half 8 or 9 o'clock. Potentially a flexi time of sorts would be really helpful for someone with rheumatoid arthritis, because classically the symptoms are their worst in the mornings. First thing in the morning, it's like a diesel engine. It takes a while to warm up. I'm not a petrol engine, I'm a diesel engine. And certainly our experience of working with people with rheumatoid is that many of them really find it hard. They need exercise or even massage or baths and so on just to get themselves moving in the morning. That's a really simple thing. It's very common. Yet some organisations, some employers just don't get that. Or they're worried that if they treat someone with this condition differently from someone else, that will cause friction in the team. It needn't do, but certainly our experience is that this is an anxiety that a lot of people have if you are suffering with an inflammatory condition. Disclosure and openness is also a really important thing. Now, this person had found an interesting way of being perhaps a bit more subtle about disclosing to her team, or at least helping them to understand when she wasn't feeling so great. So she says, I used to wear a wrist splint on the days that I felt particularly bad, because even if it wasn't my wrist, I just felt it would be a good way for people to know that everything wasn't okay without having to tell people. So there's something about what the need for being discreet. Even if you feel able to disclose you have a condition, there's an anxiety that people just don't want to hear you going on and on about it all day, in what you might perceive to be a self-obsessed sort of way. People are still very sensitive about this, and so this person found that they wear a wrist splint, for example, just so that people understood that they weren't feeling that great, that they could adjust their behaviour or their expectations. A job or a career. So this person is worried about what happens to their career. They're pretty confident about being in their job, but they're thinking about what happens next. I've decided not to go for the head of area post, but to take a role that would allow me to put myself and my condition first. It's frustrating that that is where I'm stuck at career-wise. There's no chance of progression. It can be quite frustrating, doing the same thing, knowing I'm not going to get anywhere. This next one is about self-employment. So I mentioned this already. This person made the decision. I couldn't just do a normal job and work for a normal company. The only way I could stay in work was to work for myself, where I was more in control of things. So they're just 4 quotes from people who we interviewed as part of this. And I guess my reflections on what they're telling us is that this is a really important part of empowerment. In most economies, we have knowledge economies. People are very highly educated. They're not just passive recipients of care and support, and we owe it to them to treat them with respect and help them to play an active part in the management of their condition at work. Over 60%, as I said earlier, of people with musculoskeletal conditions are the primary income owner in their household. So anxiety about job loss can be serious, but so can be anxiety about disclosure and anxiety about underemployment. So having loads of great skills or qualifications, but being in a job that doesn't use them, that can be deleterious to mental health, and that's something we need to also think about. We can't just do workplace adjustments to people. They have both knowledge about their condition and a stake in a good outcome for them and their organisation through their boss. So that supported self-management led by the worker, which is frequently monitored and updated, can improve confidence and support recovery and productivity. So I think these are really powerful messages, and I think enlightened employers are already doing this. They don't need to be shown how to do it. Particularly if you've had someone in your organisation for several years, you know what they're capable of, and you can have a grown-up and adult conversation with them that can help them play an active part in making adjustments that allow them to remain productive and a valuable member of the team. I just want to finish in the last couple of minutes by going back to this issue about job quality, because I think this is something that's quite concerning, and it's something that we should set ourselves as a standard. If all we worry about is that someone is in any job, then we're probably not doing as well by that person as we could be. So just finally to this question, is any job a good job? I want to refer to some data that's coming out of Australia, just to give you something which is probably quite challenging, but I think is important for us to bear in mind when we're thinking about returning to what kind of work. This is HILDA. Australians like giving these sort of studies names. This is a household income and labour dynamics study in Australia. 7 ways of data from over 7,000 people. What they were looking at was what they call psychosocial job quality, so the extent to which the intrinsic quality of the work that people were doing was either positive or negative for people's mental health at work. And they were looking at people in different parts of the labour market, so those people in shiny, excellent jobs, those people in poor quality jobs, and those people who are unemployed. These are the sorts of measures that they developed in order to look at what psychosocial job quality was about, so whether the demands of the job were hard or complex, how much control or autonomy people had in their jobs, how much job security they had, what the balance was in the view of the worker between the effort they put in and the rewards they felt they got out of their job. Lots of findings, but the one I'm just going to highlight for you is the following. What they found was that those respondents who were unemployed had significantly poorer mental health than those who were employed. However, this is the key thing, the mental health of those who were unemployed was comparable or more often superior to those in jobs of the poorest psychosocial quality. Now we have to think about that for a minute, because what that is saying is that any job is not necessarily a good job, and there are circumstances where, despite the fact that being in work is better for you financially and potentially in terms of your social capital and so on, from a psychological point of view, if you feel that you're in a job which doesn't have all those characteristics in the previous slide, then actually it can be worse for you. And so my final challenge really is, if we're thinking about self-management of chronic conditions in the workplace, we do need to think about the nature of the work that we give people. Because what we don't want is for people to feel grateful that they're employed in almost any job, regardless of their skills or their aspirations. In an ideal world, we need to be thinking about the quality of the work we're getting people to do, because that's where their productive capacity is maximised, and it's also where their sense of fulfilment from their work and therefore their ability to use work to derive therapeutic benefits is maximised. And I think this is something that we need to have a better debate about. So that's why I want to finish. I've given you a number of resources at the back end of this slide deck as well, so that you can follow, for example, some links to some organisations who provide practical self-management advice and support. These are just UK ones. I know there are others in Canada, North America and other parts of Europe, but this is the sort of beginning of the internet trail that you can follow. So I'll stop there, and I'm very happy to take any questions you have.
Great. Thank you very much, Stephen. I think that was a wonderful presentation, very informative. And for everyone who is listening, we will be releasing a copy of the PowerPoint as well after this presentation. And I will also list these resources on the website with the recording. So just so you all are aware of that. Now I will dive into some questions. I had one question: could you provide specific examples of mental strategies to cope with pain that can be suggested to those individuals who are contemplating return to work?
Ooh, good question. Well, I think it partly depends on the source of the pain. And I guess, let's think of an example. And we've been doing work with people, for example, with osteoarthritis and rheumatoid arthritis. And I think quite often for those people, the dividing line between pain and fatigue is quite blurred. And I mean, I think that quite often when we speak to people who are trying to cope with those challenges, they talk about breaking down the sort of coping, the tasks they want to do into small component parts, and really just trying to get to the next stage. So, for example, to what extent is my posture having an effect on my pain? To what extent are things like, how I'm getting to work or my transport and so on affecting my work? So quite often we find that one of the adjustments that employers can make for people is just providing them with later start times. I, for example, had a colleague at the Work Foundation who had cerebral palsy, and her anxiety and her discomfort was caused by having to get on the London Underground every morning in big crowds of people. And now, actually, she could cope with the physical part of that, particularly if she had her wheelchair with her or used the disabled seating. But actually, it was the anxiety that seemed to have physical symptoms for her. The anxiety about being hit or being bumped up against was a big problem for her. So what she found was that we negotiated with her that she can start later and go home earlier and so on. That helped that psychological adjustment process, and it meant that something that was a relatively straightforward thing had risen up her anxiety level to the point where it almost became the major obstacle to her coming back to work. So there's something about breaking things down, thinking about the specific aspects of the situation that causes you either mental distress or physical pain, and then trying to find immediate solutions to those, and you can incrementally overcome them over a period of time, and that's often where you need support to do that too.
Wonderful. And then there's two questions that are kind of related. One person asking about when they have difficulty as a person with a chronic condition, they have difficulty getting family and coworkers to understand their condition without seeming, like you mentioned earlier, whiny or, that's all they talk about, that sort of thing. Are there any tools available that can help people with chronic conditions communicate effectively to both family members but also to coworkers? And then someone also asked about dealing with a non-empathetic manager, which that could tie into that.
Yeah. I think I've given a link to it as well at the back end of the slide. One of the best examples of providing practical tools for this is the MS Society in the UK. They produce some really excellent material which is aimed not just at individuals but also families and also organisations. So you can download various toolkits that they provided that just enable you, if you're a manager, to get inside the head of someone living with MS and how distressing it is because it has a real fluctuating course in many cases, for example. Or people have anxiety about urinary incontinence or eyesight and so on. And I think quite often patient advocacy organisations have done a lot of work on this. Arthritis Care, we have Macmillan in the UK, which is the cancer support charity. They've all produced fantastic toolkits aimed at all the stakeholders in this process, not just individuals and bosses, but also family members as well. I think it comes also back to this thing about being solution-oriented. Of course, some people are in such pain or in such distress as a result of their condition that at times they can only think about how that condition is affecting them or the things that they can't do. We need to help them think about the things they can do, and we also need to give them a safe environment within which they can talk about those things and the distress it's causing them, but also encouraging them to think about, well, if that is your problem, what are the 2 or 3 things that could be done, very simple things to help you resolve that, either in the short term or in the long term. And I think that family members need to particularly to listen to the advice of physicians, and certainly in my experience specialist nurses in some of these areas are absolutely brilliant at explaining to family members the nature of the condition and how it affects people's both physical, functional capacity, but also their mental state. And I think that we should be investing much more in getting clinical nurse specialists to play a much more active part in helping individuals come to terms with their diagnosis, but helping family members to come to terms with it so they know how they can provide the most constructive and positive support.
Very good. Let's see, another one. Is there any evidence around the optimum length of time for a graduated return to work for someone who has been off work for a year or longer?
Yeah, that's a very good question, and I don't think there's a hard and fast answer. It obviously depends on what the sort of cluster of conditions or symptoms the individual has. Obviously, we know that the longer people are away from work, particularly from a psychological point of view, the more difficult it is for people to return. We know that I've got data from the UK that shows that if people are away from work for over a year, particularly if they're on disability-related benefits and therefore they're unemployed, statistically they're more likely to die or retire than ever return to work, which is a pretty grim statistic. But we know that, for example, in the UK we have BT, which is our big telecoms provider, where they've done some fantastic work to rehabilitate people who've been away from work for quite a long time. We know, for example, that if you work for them and you've been away from work for 6 months or more as a result of a mental illness, you've got an 80% chance of getting back to work. And that's because they work intensively, not just through occupational health and through vocational rehabilitation, but line manager involvement in staying in contact with people. So I think that for people who've been away for a long time, they really need to dip their toe gradually and gently back into the workplace. And I would certainly advise employers to make sure they're keeping in touch with people during that period. I still talk to managers who say, this person's been off a long time, but I can't get in touch with them because that would be regarded as harassment. It really isn't. quite often we talk to people who've been away off work for a long time and they say, no one's contacting me. Does that mean they don't want me to come back? So communication is really important, but it is very individual, and I think it depends on what aspects of functional capacity people are having most problems with, but it must be attempted. And I've certainly come across examples of people who've been away for 10 years who have successfully got back to work. That's very extreme, but it is possible.
All right, very good. And just to add to that too, we've had several different people who have been on long-term disability who have come and done volunteer work for our organization as a way to dip themselves back into working. And they've done, like, because it's nice and flexible, there's no, time requirements, but it does give them a structured, like, I can come for, 2 hours a day, 3 days a week, and do just some basic, desk work or, whatever it is, but building up to where they get to a point that then they can return back to a workplace office that might have higher expectations. So that is also an option for the dipping back in with maybe less of the pressure right off the bat.
It is, and I agree with that, but there is a but, actually. So in the study we've been doing, for example, looking at schizophrenia, which obviously is quite a severe illness, but the evidence there is that you have to time limit volunteering for those people. Otherwise, people's expectations are that volunteering is an end in itself, so it needs to be part of the pathway to return to work. We know, for example, if you have a diagnosis of schizophrenia, being in competitive employment, so not sheltered or voluntary work, means that you're 5 times more likely to be in functional remission or not be using health services and then be on the positive pathway to recovery. So there are countries, particularly in Europe and Eastern Europe particularly, where sheltered employment or volunteering is almost seen as the end point. And I'm not sure that's always the best option. Obviously, it's a very individual choice, and for some people, stepping back towards work through volunteering is a fantastically positive and confidence-building experience. But we just need to be careful that we need to match what people's aspirations are to the support we give them. And if they're happy to use volunteering as a route back to full-time or competitive, gainful paid employment, then we need to plan that and deliver it with them. If we satisfy ourselves that volunteering is okay and you can do that for the rest of your career, that's not always the best for the individual.
Yeah, that is a very good point. Let's see, and then we also have someone who works solely with clients who require accommodation, many of which are long-time disabled. And let's see, a question is, how do you address learned dependence or the disability mindset when you have those difficult long-term cases?
Yeah. Yes, I think there's, well, part of it I think is real. I think there's also a fear, which may or not always be justified, that people develop sort of learned helplessness as a result of a long-term disability or incapacity. But I think in most cases those issues can be overcome, but it does require time, it does require empathy, it does require supporting people to perhaps think in a different way. And I think certainly in the field of musculoskeletal conditions, some of the interventions that seem to have best effects in terms of rehabilitation to work are those that can include things like cognitive behavioural therapy, which is a way of really helping people to think differently about the nature of the problem they have. And also make different choices or conceive of their problem in different ways. And that's something which I think has increasingly been shown to be successful in helping people to think differently about the nature of their incapacity and perhaps to think a little bit more constructively about what capacity they do have that they can build on. Again, as in my previous answer, it's very individual. And I think, of course, there are erosions to people's psychological functioning, their optimism, the extent to which they feel able to to do things and succeed, the ease with which they cope with setbacks or criticism, and so on. So all those things can be very difficult. And often in people's lives they also have associated issues like relationship problems. They may have issues with housing. They may have other comorbidities such as smoking or alcohol problems and so on. So people's lives can get very complicated, and I think that's where support can really help people to cut through this and gradually, incrementally build up their self-esteem and their self-confidence. And that's where things like volunteering or supported employment initiatives can really help people to craft a return to work plan that's based on their aspirations and take baby steps towards rehabilitation back into the workplace.
Wonderful. All right, I think that's all of the questions that we have. Thank you everyone for joining us today, and thank you very much, Dr. Bevan, for the presentation. I think it was really, really helpful and interesting.